Hello, everyone. My name is Mina Tadimeti, and I am the founder and executive director of Special Needs in My City. I too am a parent to a child with special needs. Today, we have a variety of audience, actually. We've got parents, we've got educators, we've got professionals who have joined us today. Thank you so much. And I am coming to you live from Modesto, California. And thank you for being here and now. Today's event is really sponsored by some amazing organizations who have committed to helping our children with special needs. So I want to recognize number one, Valley Mountain Regional Center, two, Society for Disabilities, three, Team Stanislaus Special Olympics, and four, United Cerebral Palsy of Stanislaus. And by the way, if you are a parent to a child with special needs and would like to join our parent support group, which is quite active actually, and we have parents from all over the Northern California area. Noemi Spinazzi is a primary care physician at UCSF Benioff Children's Hospital in Oakland. She's also the director of developmental and behavioral pediatrics resident rotation at Children's Oakland and a volunteer clinical faculty for UCSF School of Medicine. She has a special interest in children with complex care needs and developmental disabilities. And she founded a specialized clinic serving patients with trisomy 21. And she works closely with California Children's Services, something many of us use, and with East Bay Special Needs Committee. She received her medical degree from the University of Pennsylvania, and she completed her residency at UCSF Benioff Children's Hospital, where she was a chief resident. Dr. Spinazzi, take it away. The mic is all yours.
All right, I'm going to start my presentation. From menstruation to masturbation, puberty and special needs does not equal frustration. Here we go. So first of all, I get no money for any of this. So I'm not going to be repping any specific product. I have no financial relationships to disclose. You will hear a lot of passion in my voice. That's all that I got to disclose. I love this. I have a lot of goals for today. I want to talk to you about the basics of sexual health and sexual education. I want to talk about real life strategies for teaching about concepts such as private body parts, their functions, teaching about privacy. And then I want to talk about the actual changes that happen during puberty and practical ways to address them with patients or your children or your students with special needs. And then, of course, we're going to do all of this with an abuse prevention lens, which is, of course, so important. And I always start this talk with the World Health Organization definition of sexual health, which is defined as a state of physical, mental, and social well-being in relation to sexuality. For this to be achieved, it requires a positive and respectful approach to sexuality and sexual relationships, as well as to the possibility of having pleasurable and safe sexual experiences that are free of coercion, discrimination, and violence. So, for sexual health to be attained and maintained, the sexual rights of all persons must be respected, protected, and fulfilled. This is a definition that applies to all, not just people with special needs, but so many things ring true when we think about individuals with special needs. Why do we even need this talk? Well, people with disabilities, whether they be physical or cognitive, will experience feelings of attraction, affection, will seek touch and meaningful relationship. The feelings and the hormonal changes that often drive them are going to be there whether or not we are ready for them, whether or not we want them to be, or we're ready to acknowledge them. So what is our role as parents, as providers, as teachers? It is to help the young adult understand these feelings and apply them successfully within the societal context, all while ensuring safety. So let's start by dispelling some common myths, because I have heard this before, such as the myth that people with, with disabilities are asexual, or I hear this more often, hypersexual, or that they can only be heterosexual, or only capable of inappropriate sexual behavior, or incapable of consent, that they can only have a partner with another disability, that they don't need privacy, that they couldn't or shouldn't be parents, and that just talking about sex would encourage someone to try having sex. All of these are myths. Not true. Not true. So, what is true? Well, people with cognitive and physical disabilities can be sexual, have sex, and enjoy sex. They are very diverse sexually, not just heterosexual. With the right support, capable of having healthy sexual relationships. And talking about sex will make someone more informed, not more likely to try it. And that and this is so important, and this is what I'm going to repeat to you over and over and over today. Inappropriate sexual behavior results from lack of education and lack of appropriate outlet for someone's sexuality. So all people need the opportunity to learn and understand about sexual relationships. Where do we learn about sex and changes in our body and sexuality and relationships? Well, most of us learn them from four different contexts: our home, our family, our parents, our siblings, TV, as well as other media. Of course, in the 21st century, other media probably comes before TV. Um, Peer to peer interactions. This is what middle school is all about for many of us, right? It's all about who has a crush on who and who kissed who, as well as formal education, our health classes and sex ed classes. What about individuals with special needs? Well, there is a real disparity because young adults and adults with disabilities usually have less access to good quality information that is presented in an easily comprehensible way. Unfortunately, many people with disabilities have fewer opportunities for socialization, which deprives them of the peer to peer education around relationships and sexuality. And many parents and family members tend to feel less comfortable talking about sexuality with their children. So, what we are doing inadvertently is insulating kids rather than educating them. And this is probably a disservice. So we are here today because we all want to learn how to support kids to be really successful in the time of puberty and in their sexuality. And so we've already taken the first step because we're here to learn and then become educators, as opposed to closing our eyes, closing our ears, closing our mouth, and wishing it all away. So where do we start? Whenever I don't know where to start, I usually start from the basics. And with everything we're going to talk about today, remember, repetition is key. You're not going to do this once and be done with this. This is going to be an ongoing conversation. We're going to repeat the same concepts in different contexts, in different sauces, from different angles, because this is how we get to learn concepts really, really well and learn how to generalize them to all kinds of different real life situations. So, the basics is the private parts of the body. When do we start? Well, if you're here today, it's possible that you already have teenage or adult children if you're a parent. So some of this might not apply, and maybe you have and maybe you have not done this before, and it doesn't matter. You can start at any point. However, there might be professionals here who get to start working on this from very early on, because really this should start really early when kids are toddlers and they're learning about all body parts. Where's your eyes? Where's your nose? And we should talk the private parts with their normal names. They should be the penis, the butt, the breast, the vulva or the vagina, depending on which one you prefer, the scrotum. Using babyish terms, can be confusing, right? Because say that we decide to use a slang term like your cookie or your flower or any other word that's a diminutive for the body parts. Well, that can be confusing, both in terms of generalization and understanding, but also if anybody ever were to have to report something not good that happened to their private part, and then someone came to you and said, someone touched my cookie, what do you mean? You know, was it the chocolate chip cookie that I gave you in your lunchbox, or was it your vagina? Because that's very different. And it doesn't, and, toddlers, right? You're not going to sit at the table and have a lecture with slides on the body parts, but it probably comes up during play, right? It might happen as you're reading books and you're naming different body parts. You could be naming things that are same and different between male and female bodies. It might come up during play. A kid who smacks your butt and you say, my butt is private, please don't touch me there. And it's important to recognize how in the moment it could be kind of funny if a young kid does something like smack our butt, but the things that are cute at 2 are not cute at 12 or 14 or 18. And so we don't want to teach the wrong lessons early on. And so being mindful of not giving attention or reacting in any excited way to any sort of inappropriate interaction with private body parts. Um, this sets the stage for having the right vocabulary to teach about toileting, about hygiene, and also, of course, puberty. And again, I want to emphasize that children who have appropriate language are more likely to report abuse. So this is important, important, important to use uh, names for the body part, for the private body parts. And once we know what they're called, then we can teach kids what they do. And again, this is another opportunity for exploitation prevention. All body parts have a job. Private parts have a job too. The penis is used to pee. The butt is used to poop. You will choose the vocabulary for the elimination functions and stick with it. And then you can introduce privacy rules into the teaching about function, right? So the penis is for peeing. Oh, the penis is private and peeing is private, so we close the door when we go to the bathroom. And only mommy and daddy and grandma can help us in the bathroom. And when I need help, I can ask mom or dad or grandma. And all of this is private. And starting to really introduce these concepts of privacy and what's private and what's public from really early on, so that we're not suddenly pulling them out of a secret hat when it's starting to be about puberty. For successful puberty, we need to know how to take care of ourselves and our body. So, even before we get to talking about puberty and sexuality, we should be talking about how to take care of our body and how do we learn that. Um, it's important to be able to break down the task into bite sized components. And for that, you can use visual aids. In my world, I take care of a lot of kids with Down syndrome and with autism. I say that visual is king. So, visual aids can be really, really helpful in breaking down a task and being a guide in case we forgot the next step. How long to do something for like brushing teeth. Who hasn't seen the kid that goes, done. So, how long, what song do we need to get through while brushing before we're done? Visual timers. I love visual timers. And of course, practice makes perfect. Nobody's born knowing how to do anything. And practice really helps. And recognizing that because we're not born knowing how to do everything, we need to praise the successes. And by that, I mean, if someone is absolutely refusing toilet training, would they be willing to sit on the potty with their diaper on and just praising that? Would they be willing to go in their diaper, but inside the actual room that's the bathroom? Because that's progress. So really just praising effort and praising success. Occupational therapy can be helpful if necessary, and if there are some sensory issues that are thwarting our efforts to become independent with caring for body parts, desensitization tools and strategies can be helpful. And for some things that kids don't like to do, and teenagers definitely don't like to do, like showering, things like developing signals that self-care is needed, or good old calendars can be helpful, so that the argument is not between you and the kid, it's between the kid and the calendar. But it's on the calendar, what are we going to do about it? It's right here, it says it's time to shower. So we now know what the body parts are called, and we know what they're there for. Here's where it becomes really important to teach about privacy. And this is just so key, because let's recognize it. Kids with physical and cognitive disabilities are desensitized to privacy. We are all up in their business all the time, right? And so, how are we expecting them to then suddenly understand that it's private in other settings when we are all up in their business all the time? So, first of all, privacy applies to 4 different categories: different parts of the body, different places, topics of conversation, and behaviors. What are some indicators that your kid might need some privacy? Um, Puberty in general, um, private behaviors happening in public spaces, like pulling down someone's pants, touching one's private area, etc., or inappropriate behaviors interfering with socialization, which to me is private behaviors happening in a public setting. And if you haven't already introduced private places and a concept of your own private space to your kid, then you could introduce it by saying, you are now X years old. You're now 11 years old. Your body is changing. You might find that you want to be by yourself and not bothered. Private places are places you go to when you want to be alone or need time to yourself. And then you can identify someone's private place. Your private space is your room. But then we need to make sure that someone knows what makes a room private, right? Because if I'm in my room, but the door is wide open, that's not so private. If I'm in the bathroom, but all the windows are up, that's not so, or all the curtains are open, not so private. So, what makes a room private? Nobody can see you. That includes curtains. Someone has to ask for permission before coming in. Parents are very guilty of this, right? We knock and then we don't wait for an answer and we come on right in. If we're going to teach about privacy, we have to be good about knock, knock, and then we wait. Can I come in? Before, and only could go in when you're invited in, because again, this is starting to reinforce some important concepts around privacy. If the door is closed, it means it's private. If a door is closed, one must knock and wait for a response. When it comes to private body parts, be concrete. Your A boy's private body parts are the penis, the scrotum, and the butt. If you have different words for it that you have been using, fine, but be concrete. A girl's private parts are the breasts, the vagina or the vulva, and the butt. And then visual is king. We can use visuals. We can say private parts are parts of the body that are covered by underwear or a swimsuit. You can have someone draw the swimsuit over the little figure. You can have someone point to uh, private parts on a picture, and so on and so forth. Remember, repetition is key. You want to do it in different contexts and different sauces, et cetera, et cetera. What about spaces? It's helpful to identify a priori some private spaces, but then it's also important to kind of tease apart some slight differences. A bathroom is generally private, but what about a public bathroom? A public bathroom is private enough to go pee or poop, but it's not private enough to masturbate, right? So there are some nuances that we might need to teach explicitly. Um, But if you are out in public and you really have the urge to masturbate, and you really really want to, then a public bathroom beats doing it in front of everybody. So, all of these are scenarios that you might need to talk through. And, if this feels overwhelming for you right now, well, also know your kid. If your kid has never ever ever done anything um super private in a public setting, then maybe you won't need to go into as much detail. If you're noticing that your kid is toeing the line between understanding what's private and what's public in terms of behavior, you really might need to do a whole bunch of different scenarios and social stories to kind of troubleshoot what's really public and what's really private. Um, and then if there are and then even with something like a bedroom, is a bedroom really private? You can say your bedroom is private, but then what if you're sharing a bedroom with two other siblings? Is that really private now? So again, you want to be concrete, and you also want to evaluate ahead of time what is truly private before you start teaching it to the kid. I love social stories. Social stories are stories where the main character is the kid. So Noemi. So in the social stories that are made for me, I am the character. I'm the protagonist. Oh my God, so cool that I see myself in the story. And the story is a start to finish story, ideally with visuals that kind of goes through a day-to-day scenario. So Noemi really had to go. Noemi was on her period, and her pad was really, really itchy. And so she knew that she had to go to the bathroom to change her pad. And so she found the closest bathroom, and she closed the door to make sure that everything was private. And she took off her pad and threw it away and put a new one in and made sure it was just right. And then she pulled up her pants and washed her hands and then went back out, and she felt so much better. Good job, Noemi. She did not take it out in the middle of the public situation. And you don't necessarily have to include the thing that didn't need to happen. The story should be about the right way that it should go. And this is a story that you might read repeatedly, but it's so interesting because I am the character in it. I'm so interesting to myself. And so it might be a lot more interesting than talking about it in a very abstract way. So, we have talked about private parts of the body. We've talked about what functions they have. We've talked about privacy. Now, 20 minutes into it, we can finally start talking about puberty. So, what is puberty? I'm going to say that a lot of these verbatim quotes are from a book by Terry Covehaven, who is a clinic manager for the Down Syndrome Clinic in Madison, Wisconsin. And I love this language so much that I use it consistently now with all of my patients, regardless of whether they have disabilities, because it's just so clear and so not confusing. So, what is puberty? A puberty is a time when your body changes from the body of a kid to the body of a grown up. These changes happen to everybody. They're normal. Some kids change earlier, some kids change later. Everybody changes at their own rate, but everybody goes through it, and it's totally normal. Timing of puberty: kids with Down syndrome, generally on par with kids without disabilities. Cerebral palsy, in general, puberty tends to happen earlier. Um, Not sure why. Spina bifida, also 20% of children with spina bifida have early go through early puberty. I didn't find data on autism. Granted, I didn't look super hard. I'm so sorry, but I didn't have time to look this one up. In general, kids with neurodevelopmental disabilities are much more likely to go through puberty early on. So if you're here as a provider or as a teacher and you teach kids who are younger, but you were just curious about the topic and you came here to learn, um, then just it's never too early. It's just never too early to start talking about this.
Dr. Spinazzi, if I could interrupt you for a minute,
Yes.
I just want to mention to our audience that this has come up again. You are muted, and your video is off. So as a default, this is being recorded without any of you visible or so no worries. And as Dr. Spinazzi said earlier, you can ask your questions in the Q&A box, and you're in a trusted space. So just wanted to throw it out there to those who have joined us a bit later in the segment. Thank you.
Thank you so much. Very important. And yes, please, no question is a silly question. I really, really believe that. No question is embarrassing. We're talking about puberty. Everything is going to make us blush a little bit. The idea is to talk about it now where it's totally safe, so that you're not blushing when it's time to talk about it with your kid. So, how do we actually talk about what happens in puberty? Well, let's be concrete. During puberty, as your body goes from the body of a little kid to the body of an adult, you grow taller. Some parts grow bigger. For girls, the breast grows bigger. For boys, the penis and the scrotum grows bigger. Hair starts growing in all kinds of new places, like under our armpit and in our private area and on our legs and more on our arms. For boys, on our face. All of this is normal. The shape of our body changes too. We boys get a lot more muscle. For girls, your hips get wider. Normal. And just like things on the outside grow bigger, your feelings on the inside can also grow bigger. You might find yourself feeling shorter or more feeling more irritable, feeling really, really happy or really, really upset. You might even start having crushes, and all of that is normal. Everybody goes through it. And as we're talking about, and so now I want to go into other nitty-gritties of what happens in puberty. And this is my slide to remind everybody to take a big breath, because really, everybody goes through this. And it is puberty, but it's really just puberty. And this is also my moment to acknowledge that I am here talking to you as a doctor. I am here talking to you not as a parent. And there is a difference between values and cultural beliefs and what I would recommend based on my medical expertise and based on what I've read in the research. And by that, I mean, it is not the job of a provider to teach a kid when it's okay to have sex or who it's okay to have sex with. These are cultural things. These are family values. This is all on you as parents to think about and decide how to share with kids, right? I am here to tell you that kids with special needs need to be taught certain things explicitly because nobody else is going to teach it to them. So this is the balance that we play, that we try to find, right? Like, how do I recognize my cultural beliefs? Maybe in my culture, it really isn't okay to masturbate. But at the same time, a kid might figure out that a penis is there and touching the penis feels good and it might happen, and then if we haven't talked about it, it might happen in the wrong place and at the wrong time. So how do we balance these two things? And again, it shouldn't be the provider's job or the teacher's job to teach someone what is okay to do or when it's okay to do it or who it's okay to do it with. These are things that are cultural and that are values. It is our job to talk about safety, to talk about health, and really, I think my job to give you ideas on how to bring things up factually to share information. So, erections. Erections are normal. They happen to all boys and men. The penis is normally soft and floppy, but sometimes it gets harder and longer. When that happens, it's called an erection. An erection is private. Erections are more common during puberty. During this time, they can happen more often and for no clear reason. However, touching rubbing, or playing with your penis will make an erection more likely to happen. So let's see. An erection is private, and touching our penis can make an erection more likely to happen. So we really need to be careful about not touching our penis in a public place, because then a private thing can happen in a public place. We should wait until we're in private. And sometimes they happen for no reason. So what do we do if an erection just happens and we're in public? Well, we can try and keep it as private as possible. Maybe if you're already sitting down, maybe you're in class, stay seated. Wait to get up. If you can't wait to get up, can you wrap a sweater around your waist so it's less obvious? Can you carry something in front of it so that it's less obvious? Um, if you're a parent and you know that erections are happening more often and you're worried about them happening in a public place and the kid being teased about it, let's wear looser clothes instead of skinny jeans so that they will just inherently hide an erection a little bit better. Masturbation. So before I talk about masturbation in puberty, I have to acknowledge that this happens in young kids and this is normal. So in all kids, neurotypical and neurodiverse, masturbation often begins very early on in childhood when there's a healthy curiosity about body parts and function. And a kid will realize that, hey, when I touch my penis, my vagina, my private area, it kind of feels good. It kind of feels calming, and it lacks the social context of this is sexual. It's just a cause and effect. I touch my penis and I feel calmer, and then maybe I go to sleep. I wiggle myself on the floor and thus rubbing my vagina, and I feel calmer when I was previously stressed. It lacks that kind of sexual context, and it's not until pre-adolescence and adolescence that the that self-stimulatory behavior starts to have a romantic and sexual connotation to it. That private nature of the behavior is more inherently understood. There's more awareness of one's response to touch, and sexual fantasy starts to play a role. And there's more anxiety about whether the behavior is normal at all. In one study, 82% of 15-year-olds were masturbating. So, you know, this is really common stuff of adolescence. And let's, some myths. Masturbation does not make you go blind. It does not make acne worse. It will not make you grow hair on your palms. And unlike what Italian people say, I'm Italian, so I was told that if you masturbate, you'll make the angels cry. I don't know about that. I don't have a direct line to the angels, but I imagine it's a myth too. So, um, not all touching needs to be handled. Let's start with that. Not all, if it aligns with your cultural and family values, not all touching needs to be handled. In fact, if done safely and in private, masturbation is okay. For some people with physical and or developmental disabilities, masturbation might be the main sexual outlet in their lives. And when we think about our lives and things that are important in our adult life and that feel good in our adult life, um, sexual expression is one of them. We go back to that WHO definition of sexual health. And so if we a priori decide, hey, you know what? You just cannot masturbate. And because you have a developmental disability, I'm just going to enforce my will on you about this. Then I just want to suggest that this might be a true disservice to the person. And so, if instead we keep a different approach to it, which is that it doesn't all have to be handled, because if it's done safely and in private, it's okay. Then all of a sudden we have a different approach to it where it's about redirecting it to be having it be a private behavior that is done safely and free of injury. um, and we need to be cautious about how we react to it, because if we are if you use very negative remarks or punishment or kind of reaction, then if anything were to happen to a kid that has to do with their penis, including abuse, there might be a feeling of, oh, but whatever happened is really wrong because the last time something happened around my penis when I was masturbating, my mommy reacted really hard about it. So I shouldn't say anything, you know? So, being I advise caution around how we react if we do see our kid masturbating, and we should react by saying, hey, touching our private body parts feels good, but it's private. So it cannot happen here. I need that, it's time to pull up your pants and go to your room. And then when we're calm, talking about if I want to touch my penis, my vagina, I should move to my private place. My private place is X, Y, and Z. And again, repetition, different context, social stories can help. So, what is problematic masturbation? If it's interfering with one's ability to participate in everyday life, it's problematic. If it's resulting in injury, it's a problem. If it continues to be performed at the wrong place or wrong time, it's a problem. So, what do we do about it? For every problem, there's got to be a solution. One, let's rule out physical causes. Is there an infection? Right? Because then that might be a reason why we keep touching your private area. Is it an issue of poor hygiene? And then there's a component of itch or discomfort that's causing repeated self-stimulatory behavior. Do we have an issue with clothes that are irritating or too tight, or maybe some chafing or sensitivity? So let's rule out those physical causes. Um, is the kid bored? Are they so bored and that's why they're masturbating all the time? Or the opposite can also be true. Are they too busy and too stressed? And so they're reverting to masturbation as a stress management technique. So evaluating how busy your kid is. Is it attention seeking? Is the kid consistently getting a whole bunch of attention when they do it? Because that could be the reason why you keep seeing it, even though you're, you know, redirecting it or punishing it. Um, Look at the medication list. Is there anything in the medication list of your child that's increasing libido? Because that could play a role. And is the private place at home really private if it's happening in a public space when it shouldn't be? Or is there an issue of generalizing those rules about public or private? Ejaculation. Ejaculation is with a little bit of white liquid comes out of your penis after rubbing it. When it happens at night, it's called a wet dream. It's normal. It happens to all boys. Ejaculation is normal. It's private. And if you ejaculate, you got to clean up after yourself. That's all I got to say about ejaculation. So then let's talk about menstruation. Periods. Getting a period means that a little bit of blood from inside the body comes out of an opening between your legs called the vagina. The blood you see during your period is a sign that your body is healthy and it's working just right. Pads are used to catch the blood that comes out to keep our clothes clean. Periods and pads are private. We want to use visuals. Ideally, we use calendars to mark periods. And then, of course, periods are private. They need to be handled in private and discussed in private. At home, I can talk to my mom, my dad. At home, I can at school, I can talk to my teacher, my aide. At work, I can talk to my colleague. So having someone identified who's in on this private thing and can support us. Pads are hard. Pads are hard. And there are so many things involved in pads. First of all, recognizing when we got to start using it. Then we got to know where they are. Then we got to know to change them in private. We got to know how to change them correctly and when to change them. And we need to know when to stop. And we need to know how to stay clean and throughout this whole thing. So full disclosure, I distinctly remember being a teenager and getting a bunch of these wrong repeatedly, including putting the pad wrong on the underwear, stopping too early, starting too late. So, you know, this is the rocket science of a kid who's new to periods. And there's definitely a lot that we can do to support. Of course, I'm going to bring up visuals, including visuals for how to use my pad and how to throw my pad away. Um, there's how to use it with wings or without wings. I like the idea of using, so first of all, we don't learn well when we are stressed, when we are, in a time crunch and it's like the moment of stress, right? So a kid is not necessarily going to be at their best in terms of learning the fine motor of how to put a pad on if they're stressed out because they're trying to change a pad and they're on the toilet and there's someone hovering over them. This might be something that you want to do as a fine motor activity as part of your working on fine motor stuff at the table, like homework, you know, no big deal. And this is what we're working on. Um, Food coloring can be helpful because with food coloring, you can put just a few drops. Is it time to change yet? Probably not. It's just a few drops. Or, and it's all over the place and also on the underwear. Is it time to change yet? It was probably time to change a couple of hours ago. This is really, really full, right? So you can use household stuff to also drive some points home. And it's easy to get this wrong, so let's troubleshoot. The pad is always going in the wrong place and it's not catching the blood. My favorite solution to this is mark where the pad is supposed to go on the underwear with a Sharpie, because then you can really tell where it's supposed to go. The top is supposed to go, where the bottom is supposed to go, and then it's not going to be too far forward, too far back. And then demonstrate and practice. The pad continues to be too saturated and we're bleeding through it and staining our underwear. Well, maybe we need higher absorbency pads. Maybe we need the wings on the pads. And we probably need to spell out the frequency of how often to change. If the pad continues to be saturated, it's time to talk to the doctor because maybe we're really having heavy periods and we need to talk to the doctor about a workup for heavy period. Is there odor? Are we changing enough? And that might be an issue of working on a schedule, reminders, doing it at times of transition. Is it a hygiene issue? So then we might need to review techniques for cleaning our private area, maybe taking daily showers when we're having, or baths when we're on our period, or using moist wipes during period. Any other symptoms along with odor? Maybe it's time to see a doctor to rule out an infection. What about someone who's just refusing to wear a pad? Well, is there pain? Some kids can get pimples and boils in their private area, and if it's painful, you're probably not going to want to put a pad on top of it. Is it maybe a reaction to the pad? Maybe the pad is scented. Maybe we're allergic to the pad, and then it's just so uncomfortable. Maybe we just need a lot of positive reinforcement. Maybe there's absolutely no motivation to do it because who cares if there's a little bit of blood on my underwear? I just don't want to do it. And so what we need is a lot of motivation and reinforcement. And then if it's really not working, then we might need to consider pads. What about if we are continually removing the pad in public? Well, we might need to remind someone that that's a private behavior and that the bathroom is the appropriate place and escort someone to the bathroom and help as soon as they start doing it. If it continues, then using clothes that are a little bit harder to remove might be a strategy as well. What if we're continuing to stop using pads but when it's too soon? We should remind someone of the purpose of pads and do some review of when it's okay to stop wearing pads. And maybe if someone has really regular period and we kind of know how long someone's period lasts, you could even mark it on the calendar. Okay, your period started today, so we're going to stop wearing pads next Monday. And then it's a very clear date as opposed to a guesstimation. And what about the kid that continues to refuse? Well, at this point, we might need a behavior assessment to truly dig into what is happening. Maybe we need an occupational therapy referral to look into sensory issues. Maybe we really need to look at medical options to suppress periods. And then I just want to call out, we live in the 21st century and there's other options. So there are underwear that catch the period blood and they're not a pad. And there's different brands. This one happens to have Shark Week on it, which made me laugh. Um, and they catch the period blood and they're not as uncomfortable as having a pad. So sometimes it takes thinking a bit creatively to solve a problem. We talked about the potential for a medical treatment to stop periods. What's out there? Well, there's a lot. There's really a lot of options. First of all, not all periods need to be stopped. It's okay to have periods. And if for some people, the time of having a period is associated with significant behavioral dysregulation. For some people, the periods are really heavy and they're leading to anemia. So there might be some medical reasons for wanting to control the period medically. What's out there? There's the depot injection. Um, Everything has a pro and con. So the depot has some pros. It actually raises the seizure threshold, making it harder for someone to have a seizure, and it does not interact with antiepileptics. And it can really suppress, take away the periods altogether. But I'll be honest, depot is not my favorite medication. It lowers bone density, it can cause weight gain, and it can cause depression and mood changes. So, not my favorite. Um, Birth control pills. They're easy. You take one a day and you're done. And if you are trying to avoid periods, you can just skip the sugar pill week and that will suppress a period for that month and go straight to the next pack. It is a daily medication, so it's easy to forget. There's two types of birth control pills, one that has both estrogen and progesterone, and one that has just progesterone. The progesterone one needs to be taken at the exact same time every day to work, and the estrogen containing ones can interact with other medications, and they are contraindicated for people who have migraines with aura, so a migraine with a telltale kind of change in sensorium before. There's an Explanon. An Explanon is a little implant that goes here under the arm. It lasts 3 to 5 years. It's very effective. It often suppresses periods, although before that, it can cause quite a bit of spotting. And it's a procedure. It's a fairly easy procedure. It's a little bit of a numbing medicine injection here, and then it's this device that goes in with a fairly big needle that at that point you're not feeling because you had the injection, and it kind of goes in and then you're done. So it is semi-invasive, but not so invasive. However, for someone who has needle phobia, who usually needs to be held down for things like a shot or a blood draw, you might need to have some sedation to get this done. And then the IUD that goes in the uterus through the cervix um, lasts a long time. It's a very effective as far as contraception. The hormone containing ones will suppress periods. Um, while the copper one can make periods heavier. So if you're doing this because you have periods that are too heavy, this is not the right choice. Um, but it's a procedure. It's something that needs to go up your cervix and into your uterus. It hurts a bit when it goes in, like some cramping. So for many kids with developmental disabilities, it might be something that requires some sedation to get done. But it can be combined with other things that you might be going to an operating room for. And what's right for your person depends on them, depends on everything that's going on, and it should be a conversation with your doctor. I wish I had another like 2 hours to talk about relationships and dating, because after we've talked about all of this puberty, um, you know, we also want to talk about sexuality and relationships, and there's just not enough time to cover it all. So I'll give some basics. And that is, before we start talking to anybody about dating and boyfriends and girlfriends, we should be talking about what makes someone a good friend. And this is actually so important because so many kids, neurotypical, neurodiverse, there's a lot of not so good friends that we identify as friends, but that are really not treating us as such. So, what makes someone a good friend? They're there for you, they lift you up, they don't put you down, they like the same things that you do, that you like, they are available when you need them. Just thinking together about what makes a good friend. That's really a good start. And then we live in the 21st century where being online is like being alone in the middle of a busy square. Um, so also recognizing that, hey, what makes someone trustworthy in the online world, and how do you know that they're really who they say they are? And talking about these things is just so important. And then again, as you start talking about relationships and dating, uh, what makes someone a good partner? What makes a relationship a healthy relationship? And I have really changed how I counsel my teenagers with and without developmental disabilities in my practice, because what we are taught in medical school is to ask, do you like girls? Do you like boys? Are you having sex? Are you being safe about it? And really there's so much more to the conversation than that. And so now I start with what makes a relationship a good relationship. And it's so interesting to hear kids talk about things like honesty and trust and consent, and talking about what consent really means, and what does it mean to give someone consent, and can you take consent away once you've given it. These are really important conversations. And then what are the signs that a relationship is an abusive relationship, and talking about that. And then talking about sexual health and risk reduction. So you have been dating so and so for a while now. Are you think and maybe you're thinking about kissing them, maybe you're thinking about doing more stuff with them. Let's talk about it. I want to support you in having a really healthy relationship. um and what does it mean? I had a um mom that brought her teenager to see me, and mom was really upset because the kid was caught with his girlfriend in the school bathroom having sex. And I talked to the kid one on one, and I was like, so what happened? And he was like, well, we were having sex. And I was like, well, what were you doing? It's like, we were kissing. I was like, okay. And then what else were you doing? He's like, and I touched her boobs. I was like, okay. And what else did you do? That's it. And so, like, what does it even mean for someone to have sex? What we think of when we think of oral sex and when we think of penetrative sex might not be what your person is defining as sex. And talking about how to stay safe through all of this is important. Well, I can tell that you really like your person. I can tell you really like them and that you are really attracted to them. And doing this in the school bathroom is just not safe. And let's talk about how to do this more safely. Um, because my priority is for you to be safe and healthy. Um, and then, as I mentioned, safety and exploitation prevention, and I want to say a few more things about that. I just have one slide on sexuality in individuals on the autism spectrum. And this is to remind me to tell you that there are some behavioral and information processing differences that could make dating a little bit harder for someone on the autism spectrum, like difficulties reading cues. What is flirting if not, tiny facial cues? Taking things literally can make it difficult to flirt and date. Um, Language impairments can impact consent, and this is a really big deal, of course. There can be specific sensory interests that, as well as hyper and hyposensitivity, that could be off-putting to a partner. Some sex might feel too rough to a partner because it doesn't feel like much to the person on the spectrum. Same with masturbation and masturbatory behavior. Someone might be going at it a bit too hard because they don't feel it quite the same. Um, there could be some preoccupations and compulsiveness and specific rituals that could impact um, the um, the sexual experience. And while for some people on the spectrum, this is not a big deal, for others, it can take a long time to get the gist of it. And a therapist can help a person on the spectrum get the lay of the land around this. And there is a wonderful show on Netflix, Love on the Spectrum, that I have enjoyed watching, and that it at least begins to address um, the story around dating for people on the autism spectrum. And while, of course, it doesn't represent everybody's experience, I appreciated that it was not the usual mediatic representation of people on the autism spectrum. Having gender identity differences is also more common in people on the autism spectrum. So not necessarily just being transgender, but also genderqueer or agender is more common in people on the autism spectrum. I hate to and have to end my talk by talking about abuse because I wish that I didn't have to, but I do because this is the reality. The overall incidence of abuse in people with developmental disability is at least twice as high. I unfortunately think that this is a gross underestimate because there's issues with reporting and with people who report being believed. Um, 68 to 83% of women with developmental disabilities will be assaulted in their lifetimes. And assault can take on many forms. Someone with a milder disability might have a desire to fit in that leads to encounters that were not with the person's consent. And uh, people close to the person's life are much more likely to be the perpetrator, with only 14% of those abused having been abused by a stranger per Department of Justice data. And again, that there's a piece of this that comes from learned compliance. There's a piece of this that comes from being, having had people in your business at all times and being told to do it a certain way, and you have to listen and you have to comply and obey. That can make us less alert to potential dangers. So we have to teach abuse prevention. Um, and this includes teaching someone with a disability that they can say no. And also they learn how to hear no as well. But ability to say no is built, right? And so what I do is I give all of my patients, starting from a very young age, the right to decline parts of their exam. And if it's something that I simply cannot forego, then I don't word it as a question, right? If someone comes in with ear pain and I have to look in their ears, I'm not going to say, "Can I look in your ear now?" I'm going to say, "I'm going to look in your ear now. How can we make this comfortable for you?" Right? But if I say, "Can I look in your ears?" and they say no, I say, "Okay, well, this is your body and I respect it. I want to give you a chance because I am the doctor, and this is your chance this is your chance to get a good full check. But this is your body. Do you want me to look in your ear? No. Okay, this is your body." And before I check anybody's penis or vagina or breast, regardless of their age, I say, "I'm about to check this. I do this because I'm the doctor. This is a very private area of the body, so I need your permission and your mom's permission." I turn to the parent and I say, "Do I have your permission?" And then I turn to the kid and I ask them for their permission, and I wait. Because if we are not the ones who are modeling this kind of right to refuse in situations where the stakes are pretty low, then when? And then the ability to hear no is important too. Is it okay to touch someone when they don't want to be touched? How do you know if someone wants to be touched? What is respect? How can you tell that someone doesn't want to go further?
Dr.
There can
Spinazzi,
be visuals.
if I can interrupt you for a second, we have a couple of questions that we'd like to, just general questions. Some of the attendees would like to know if your slides could be shared. Um, I
I
don't know.
thought that we had 30 more minutes for Q&A. Am I wrong?
We're at 4 o'clock. Questions are from 4 to 4:30.
Perfect. Yeah, I
Yeah,
have two
yeah,
more
you're fine.
slides.
Yeah, you're fine. I just wanted to make sure that um,
Yeah, so these slides are on our clinic's website, and yes, they can be shared. There are some visuals that we can use to make it easier to talk about parts of the body that are no touch or no tickle zones, as well as circles of trust of people. So who is in our green zone? Maybe it's just your parent and your doctor who can check, and maybe it's just your parent and your doctor with your parent present, or whoever you decide, knowing your person's world, who's in that green zone, and then varying levels of distance, right, and permission. And there is some safe touch coloring books that can help work through this as well. And then just having a high suspicion for abuse for all of us teachers, providers, and parents. A new refusal to go with people or to places that we're previously comfortable with. Any behavior change, including more anxiety, frustration, more self-injurious behavior, and change in the frequency of masturbatory behavior or sexualized behavior, even changes in bowel or bladder patterns. Of course, we're going to do medical workup as well, but abuse should be one of the things that we check off in the potential cause for these things. And I just want to end before we go to questions by saying you're not alone in this. So your doctor can be of support. The law says that by 16, your child should have an individualized transitional plan at school. Although this can start earlier. You know, the law says by 16 you better have an ITP with transition goal, but you can have goals that have to do with adulthood that start sooner. And remember that education goes beyond academics. Education prepares us for life. There can be behavior therapy, there can be talk therapy and mental health therapy, occupational therapy, and then there's a lot of books that can help. I really like The Girl's Guide to Growing Up and The Boy's Guide to Growing Up. They're written at a second to third grade level. They're full of pictures, and they're meant to be shared with the person with a disability. And then the book Teaching Children with Down Syndrome About Their Bodies, Boundaries, and Sexuality is a book that I have read a couple of times, and I've relied on heavily to make this talk. And it does not just apply to people with Down syndrome. It has awesome language, great worksheets. I strongly recommend it, as well as these other resources. And Planned Parenthood has a booklet too. Marsh Media has some other resources. And yes, with that, I'm gonna stop sharing my screen and open it up to questions.
all right. We have several questions, and we also had several questions emailed to us prior to this webinar. There's one question I wanted to ask you that came from a parent through our email, but goes like this. My son is 19 and sometimes masturbates up to 3 times a day. This has been going on for a couple of years. I talked to the pediatrician and his psychiatrist about it. He's never ejaculated and so rough that many times he's bloody. I bought him lubricant to see if that would help, but he won't use it because of the texture. Is it normal? And is there anything I can do about this? And this seemed to be a theme from many parents. So I wanted to pose that question to you.
Yes, so I want to go back to um, this. So this to me would fall in the problematic masturbation category
Mm.
because there's physical injury. And it sounds like a discussion has happened with the doctor about whether there might be infection. And, is there an issue with how busy the kid is? Does the kid need to be a little bit less busy so that they have fewer chances of engaging in this really rough masturbatory behavior? Um, and um, or maybe they're so stressed and maybe we need to reassess what's going on in their life and decrease the stress a little bit. It sounds like a doctor and a psychiatrist have already looked into um, the medication question. And then the the lubricant idea is a good one, and I would say, have we tried all types of lubricants? There's a lot of stuff out there. If the water-based ones are not enough, then are there other ones that have a different texture that might work better for your kid? Because I think that a lubricant is a good idea because it seems like some of this is just rough from the rough rubbing. And then, is it an issue of it's just going for too long and there's no ejaculation, so it just keeps going and that's what's causing the injury? Or is it it's happening a little bit too roughly, like someone is going too hard? In which case, is it a sensation issue, like I'm not feeling it enough? And then what comes to mind is, there's lubricants that have like that create a sensation of heat or of cold, like would that kind of change? And I would do this cautiously, but I also would, if the person can talk, and if not, in whatever way they communicate, when you see that the kid has masturbated for a while and then there's blood, does it hurt? Because if it hurts, then we can work around this. um I don't know if the person we're talking about is on the autism spectrum, but this I've encountered this before with individuals on the autism spectrum. Changes in hygiene were helpful, actually, because sometimes it was that it started with an itch and then it turned into masturbation. Um, and so if it is someone who has behavioral services, because they are on the autism spectrum or whatever, then even considering talking about it with a behavior therapist, maybe there needs to be a behavioral assessment to better understand the why someone is engaging in it so much. And maybe it's working with an occupational therapist to get used to the feeling of lubricant so that we can make this safer.
Thank you. The next question comes from one of our attendees, and the question asks, would you recommend talking about menstruation about girls to teenage boys, or should we wait till a certain age?
I mean, I don't see why not. I just would keep it simple. I would say, I would say it I think that in the context of wet dreams and ejaculation, it's like this is normal. Girls get a period. A period is, and when they get a period, there's a little bit of blood that comes out for a few days out of the month. It's totally private, so you don't want to bring it up to them because it's private and they might be embarrassed. But especially, but hey, I'm your mom and it happens to me once a month. um your sister, that's so, I don't I'm about education. I'm not about hiding.
Mhm.
I think that as you're explaining things, and you're just like in sex ed, we don't just learn what happens to our gender, we learn about what happens to the other gender too. We should apply the same principles to kids with disabilities. I believe that so strongly. I think that the timing should make sense. Like I wouldn't do it where like you're trying to really master concepts that are directly important to the boy, like erections or masturbation, and then you're throwing menstruation in there at a time when they're confused about the other thing that you're talking about. I would do it at a moment where the kid is ready to learn and it matters and it's meaningful.
Thank you. The next question comes from a parent that writes, I have an adult, I take that back. I don't know if they're a parent or a professional. So I have an adult client with ID and CP who craves pornography. This has been very costly for the family, and they now discourage all non-supervised computer or TV use. His past counselor encouraged masturbation. The parents are convinced that he has no feelings in his penis, and they do not want to encourage the stimulation. Any suggestions?
People with cerebral palsy can have sensation to their penis. It depends on what type of cerebral palsy they have, if and why. If they have spastic diplegia, so spasticity of the lower extremity, versus quadriplegia. Do they have a traumatic injury to their spinal cord that would take away sensation to the penis or not? So that first part of not thinking that the kid doesn't have sensation to the penis, there's a piece of this that I don't fully understand, because the diagnosis of cerebral palsy in itself does not mean that someone doesn't have sensation. There's no reason for me to think that. I have a lot of other questions. Why is the kid so engrossed with pornography? Pornography, there are people who are addicted to pornography. It is something that is, stimulates the reward part of our brain. There's a lot of novelty. It's quite extreme. Has the person experienced abuse themselves, and that's why they're going to pornography. It's a way of kind of processing, reliving what's happening. And then why does the adult person have the credit card that allows someone to overspend on the internet? This is not just because it's porn. If I'm on Roadblocks or whatever, or Fortnite, and I'm overspending because I'm a kid, then I'm not going to have the credit card anymore. So to me, that there is so much to this, including, I'm not sure about the sensation thing, and that would be something to be discussed with the person's physician, because they would understand the person's physiology and comment more properly about whether they have sensation or not. I understand that pornography is highly exciting and can be addictive, and I would just want to make sure that the pornography is not overtaking the person's life, because just like any other person, then we would want to intervene in a mental health informed way. And why are they so into porn? And also, if it's a financial thing, change your credit card number.
Thank you.
But I would put some therapy in it, and a consultation with the doctor about the sensation question.
Thank you. The next question is, how can we teach my 11-year-old boy how to masturbate? He gets erections and does not know how to handle it. He keeps asking mom to help him.
Well, erections don't necessarily need masturbation to go away. So the question is the kid asking, that's a good question. I'm pausing about it. Is the kid asking mom help because it's new and he's confused because the penis is erect and they don't know why? Or is the kid asking for help because they understand that something needs to happen about it and they don't know what? I if it's the former, the first thing I would do is I might start with some education about what are erections. Oh, that looks like an erection. An erection is normal. The penis starts out floppy and it becomes hard, and you just wait it out and it goes right back to being floppy. So let's just give it some time. Let's get distracted and watch some TV or something like that. And if that solves the situation, then the kid wasn't asking for help masturbating. The kid was asking for help because something really novel was happening. And then if it seems like the kid is asking for help because there's like a feeling, a desire, but they don't know how, my gut reaction is I wouldn't show them how to do it. That doesn't feel right in my gut. But what is the right answer? Are there books about it? Are there videos about it? I would have to read into some of
Mhm.
the books and stuff to go into that. But I wouldn't perform the masturbatory act on the kid. That feels like something that we shouldn't teach our kid is okay. And yeah, my reaction is I wonder if the kid is just asking for help because it's something new that's happening, and then it's about, oh, that's normal. And then when it happens, some people choose to rub their penis. Some people just let it be and then it goes away. And then it's just something neutral like that.
There's another question very similar to this, and I think it centers around the same theme, and that is, what do we do if our child will only masturbate when we're present and asks for help? And I'm not sure if the question is saying, that the child or the individual would like to masturbate but doesn't understand what's happening to the body and is asking for help from the parent.
Yeah. Ooh. My philosophy is in life is when I don't know the answer, I say I don't know, but let me see who I can ask. I have given my presentation in conjunction with a therapist who does sexuality work with individuals with disabilities. And if you remind me, please,
Sure,
I will reach out to them and then I can feed you the answer back.
sure. Thank you.
My again, my I'm trying to I'm going with my principles of, provide education and while at the same time setting boundaries, so um, that is private, and as your parent I can't help you with that. um, it's something super super private,
Mhm,
that and then figuring out how to word who could help you with that, because it would have
mhm,
to be someone you've been with for a while who you trust, and like a relationship, but
mhm,
also being clear about what that means, because um, we define relationships, like defining a relationship can be tricky for a young person. Um, and I mean, my feeling is that to me needs to be redirected and someone needs to be reminded that it's private, and acknowledging that I see that you need help and it must be frustrating, and I just have to set this boundary. This is really private, and as your parent, I can't help you with that. Um, and then, maybe, but also education, what kind of materials might be out there that could teach that person how to do it. But I wanna, this feels important, and so please send me this
sure.
question and I
Yes.
will do some extra research.
Yeah. And the follow-up to that question by the individual is there any provider like who you were referring to, that works like a sexuality worker, not lack of a better reference, um, that families can have access to.
Yeah.
We have our pediatrician, we have our primaries, but we don't know how to get to that person who specializes in what you were referring to.
Yeah, so I only know of this one unicorn,
Okay.
and she practices in the San Francisco area, and
Okay.
for the most part doesn't take insurance.
Mhm.
Um, but I can ask her if she knows of others. Um, I think that a therapist in general can be a good start. A safe person with whom you do confidential work and creates a safe space. Um, but there is a piece to it that comes with expertise and with having the right terms and the right words, and I do think that just like there's a dearth of professionals that choose to work with people with developmental disabilities in the mental health arena, that's even more true
Mhm.
of therapists who do sexuality work.
We will take two more questions, if you don't mind. And one has to do around the theme of periods. So one of the questions that comes in, very similar to many other questions in the same spaces, my daughter is 10 years old and masturbates at night. She also does it when she's on her periods. I worry about the hygiene part, rubbing her eyes, touching her hair at night. Any tips with hygiene aspect? And two, is it damaging her vaginal lining if she masturbates during her periods?
It's not damaging. It's messy. And if that's the issue, then you can make up some rules, if you will. You could say you can masturbate anytime you want, but when you're on your period, it gets a little messy. So um, it's gonna be less messy if you hold off when you're on your period. If you do masturbate while you're on your period, you have to wash your hands afterwards. And maybe you know that your kid's on your period, and you put some wet wipes next to their wherever they do it, so that there's a visual reminder of I at least wipe my hands, because there can be a tired and lazy factor of I don't want to get up and wash my hands. Um, it's not damaging. It's messy.
Okay. One last question we'll take has to do with the theme of at the school environment.
Hmm.
Many questions came in asking, we often get messages from our IEP team members that my son, is touching your son is touching his private parts at school, and and the parents are often overloaded with not knowing what to do with the situation because one, they're not at the school when it happens, but as parents, what do we do when school calls and or emails us and says your kid is touching his private part all the time, or your daughter is doing these things? And is there any particular components that could be brought into the transition plan or into the IEP plan? Because right now many parents will attest there is nothing really being done in this space when students are exploring their bodies at school.
Yep. So there's the teaching that that touching your privates is a private behavior and school is public, so don't do it at school. And that is the part that a parent can do. And then ask for a behavioral assessment and ask for a behavior plan. Um, uh, the end. Oh, it's happening at school? Oh, it's disrupting your class? Great. I'm asking for a functional behavioral assessment so we can develop a behavior intervention plan so that this behavior that seems to be disrupting your class and my child's learning can be redirected appropriately. Back on the
Very good.
school. Back to you, school.
I don't know, we service over 800 families, and I don't know how many times I've heard this. As a parent, what am I supposed to do? I don't know. I'm not at the school. Yeah, when he
Correct.
comes home, I tell them, but
Correct. No. Correct.
yeah,
Correct. And has there been a change, right? Because if a kid was never ever has been going through puberty and has never ever done it before, and then all of a sudden they're masturbating a whole bunch at school, I go back to the slide about what the heck is going at school also that's making a kid masturbate like that all of a sudden. Is anybody doing anything inappropriate to the kid? Number one. And two, is the kid so stressed at school that they're reverting to a stress relief kind of behavior in the school setting? So there is and I get eczema, like I get hives when you tell me this, because of course, if it's happening at school, what is a parent supposed to do? You can go back to, talking about it in education, but really the intervention needs to happen at school if the behavior is happening at school. And the intervention is not going to be calling attention to it. The intervention is going to be, let's develop a behavior intervention plan, call an
mhm.
IP meeting. Hey, you keep calling me about it. I wrote it down. You called me on this day, on this day, on this day. I'm calling an IEP meeting to discuss this because it seems like we have to meet as a team.
Thank you.
Thank you
Sure.
for having me.
Yes.
And thank you to all of you for having awesome, awesome people, awesome kids who make our world so much better.